So thank you for the kind introduction, and thank you to the organizers for inviting me here. It's a great honor and a great pleasure to be here in China and talk about cardiac biomarkers. So thank you very much. I'm very glad to be here. So I'm going to talk about some recent updates on the educational recommendations from the IFCC Committee on Clinical Application of Cardiac Biomarkers. Yes, these are my disclosures. And then a brief overview of my talk. First, I will say something about the educational tools the IFCC Committee has provided, which you can all use. It's free, available online. Then I will talk about the 99th percentile upper reference limit for troponins and why that cutoff is so important. Further on, we will discuss the single sample rule-out of non-ST elevation myocardial infarction and analytical performance. What goals should we have for the analytical performance at low troponin concentrations? And in the end, we will say a little bit about interference on troponin assays, and then there will be hopefully some conclusions. So this is the webpage for the IFCC Committee on Clinical Application of Cardiac Biomarkers, which is of course under the web pages of International Federation of Clinical Chemistry. Just to show you here on the left side, I've highlighted a few things that you could take a look at. First of all, it's the biomarker reference tables. These are for troponins, natriuretic peptides, and we think they are quite useful both for researchers and for routine laboratories. These tables provides all the important information about the assay. So all assay characteristics can be found here for all available assays, like the LOB, the LOD, and so on. So also here you can immediately see if this is a high sensitivity assay or not. So if you see on the left-hand side here, we have some information about percentage of normals which are measured above the LOD, percentage of healthy measured above the LOD. And here, for instance, for the Mindray assay, you can say that that is more than 85%, both in females and males. So this is actually a very, very good performance. Also, we provide the concentration where the assay has 10% CV and the CV at the 99th percentile. And as you know, to be a high sensitivity assay, you need to have a CV of less than 10% at the 99th percentile. Here is 3.7%, and you also need to have measurable results in more than 50% of healthy subjects. So this is an example of a truly high sensitivity assay, and it's a very good performance. Also, we have a lot of manuscripts that are published, which you can read. Most of them are open access, so it should be available. The webinars from the committee is available online, and we also have some podcasts. This is the last thing we started, so there are not so many yet, but hopefully we will be able to provide more of those. So, the 99th percentile upper reference limit for troponins is a very, very important cutoff. And the reason for that is that this cutoff is used in the clinical diagnostic definition of myocardial infarction. And this picture was also shown by Professor Plubani yesterday. So this is a very, very important part of this guidelines. And troponin is a special biomarker because it's one of the few biomarkers that are actually embedded in a diagnostic definition for a disease. Most biomarkers are used to support the diagnosis, but troponins are actually part of the definition. So you cannot have a myocardial infarction unless you have specific findings of the cardiac biomarkers and then the troponins. So what we need is to have at least one measurement above the 99th percentile, and then also a rise and fall in the troponin concentration. In addition, as Plebani also told you yesterday, you need clinical symptoms and signs of ischemia or ECG changes or other imaging findings. So, since this cutoff is used in the diagnostic definition, it's very important that it's as good as possible standardized, so that the diagnosis of a myocardial infarction should not be dependent on which assay is used in the hospital or which hospital you are admitted to. It should be standardized. What we know about the 99th percentile is that the cutoffs are assay specific. And this will, of course, increase the variability because there will be different study defining the 99th percentile for different assays. And then we need to standardize how we do these studies so to reduce the variability in the cutoffs presented. They are assay dependent, and also very important to acknowledge there are sex-specific differences in the troponin concentrations. So women will have approximately half the concentration compared to men. So for a woman, there is much lower concentration needed actually to fulfill the criteria for a myocardial infarction. We don't know exactly why it is like this. Usually, earlier it was believed that this was due to men, they have larger body size compared to women, and therefore they probably also have larger hearts. And then it was hypothesized that due to the larger hearts, the troponin concentration should be larger. However, there are some recent indications that it might not only be due to differences in size of the heart, but also maybe differences in sex hormones. So maybe testosterone will lead to higher concentrations compared to estradiol, which is the sex hormone of women. But anyway, for every assay, the concentration in men is approximately double the concentration in women. So, as I said, it's very important that there is quite similar cutoff, or the cutoffs are derived in a similar way for all assays. If not, differences between studies might lead to differences in how we diagnose myocardial infarction, and that can affect patient care. So therefore, we gave some very recent recommendations or suggestions for how to derive the 99th percentile so that researchers and manufacturers who do these studies can have a framework to lean on so that it will be designed in a similar way. As Professor Plebani said yesterday, it was at least 300 individuals for every sex, but now unfortunately we have changed the suggestions and increased them. So now it's more work for you. You need to have at least 800 healthy individuals, 400 men, 400 women. We also suggest that you should include a wide age range from 18 to 80 years, which is applicable for the patients with chest pain, and also that the relevant ethnic groups in that geographical region where the assay is used is also represented. In addition to this, the individuals included in the study should be healthy. So how do we define a healthy person? That is not always so easy. But what we suggest is that you do some questionnaires and ask about cardiovascular disease, chronic disease, risk factors like hyperlipemia, hypertension, diabetes. You look at the BMI. Smoking, we know for some paradoxical reason that smoking reduces the troponin concentrations. This is, we don't know exactly why, because this is a risk factor for cardiovascular disease, but still smoking will decrease the concentration. Also, we recommend to use blood tests like hemoglobin A1C, creatinine, and NT-proBNP to exclusion criteria, so that you are sure that you will not have anybody with subclinical disease included. This is an example, a very recent study from Professor Zhang's group, a very good study, and published in one of the top clinical chemistry journals, of course. And this study gives the suggestion for the 99th percentile upper reference limit for the TNI assay from Mindray. And as you can see, and I was very pleased, this a large number of both men and women here, more than 400. They have a very impressive age range, going all the way up to 87 years. It's very good to find a healthy person of 87 years, so I assume this is because Chinese people are so healthy. So this is very good. And also, the 95% confidence interval for the cutoff has been calculated. That is the reason why we suggest 400 in each group, because then you can calculate the 95% confidence interval. And as expected, the concentration is approximately double between men and women. We also say something about statistics and outlier detection, because the way you do the statistics will very much influence the results and the data of your study. So if you look at a new assay, for instance, you can check how the statistics and outlier detection is done, and in that way evaluate if this is a good study or not. Pre-analytics is also important, and yesterday Professor Plebani said that troponins do not show diurnal variation. Well, I disagree a little bit. It's correct that troponin I does not show diurnal variation, but troponin T does. This is probably something about metabolism, and I apologize for not writing troponin T here, because it should have been troponin T. It's not shown for troponin I, but for troponin T. It's higher in the morning compared to later at the day. So also there are assay-dependent interference like hemolysis, lipemia, tube additives, and so on. So you need to check this for your assay if you want to do a study. There is one important thing with immunoassays, that they all show lot variation. And this lot variation can be significant, so therefore we do recommend that you use several different lots when you calculate the 99th percentile or do a reference limit study, so that if you have a very high or a very low lot, that should not influence your data too much. So, we also discussed yesterday about the single sample rule out of non-ST elevation myocardial infarction. And This group has also said something about that. This was shown yesterday, so I will not go into too much details, but as you know, when patients present with chest pain, we do the ECG. If it's not a STEMI, according to the ECG, the patients will be further evaluated with troponins. And based on the troponin levels, we can risk stratify the patient into high or low risk. And then we use this system, so if you present with more than 3 hours of history since onset of symptom and a very low concentration of troponins, similar to the LOD of the assay very often, then you have a very low risk of myocardial infarction. It's only 1% of NSTEMI patients who have a concentration below this very low cutoff when they present, so it's very rare. So you can be very sure that, that this patient do not have myocardial infarction if they present with a very low concentration. On the other side, there are some patients who present with a high concentration, and they have a very high risk of myocardial infarction and should go directly to the cardiac ward for evaluation of NSTEMI. And then you have a large group in the middle who have a short time since onset of symptom, or they have slight elevations being between the LOD and the 99th percentile of the assay, typically. And those patients need to be evaluated with a second sample taken 1 or 2 hours after admission. So single sample rule out is actually a way of risk stratifying the patients, and we hope that this can, or the intention is that this should speed up the patient flow through the ED, so patients do not need to wait in the ED, but can either go to the cardiac ward or be discharged. However, be aware of that other urgent conditions that are not in STEMI, they are not ruled out. So if the patient has a pulmonary embolism or some other serious condition, you cannot detect that. It's only in STEMI that can be ruled out by this algorithm. Also, it takes a little while, 2-3 hours from the symptoms starts, until we can be sure of detecting the troponins. At least this is for the current assay. Maybe that will change in the future, but it takes a little bit of time. So therefore, you need to wait until, or if the patient comes to the hospital before 2-3 hours have passed, then you need to take a second sample to see if the troponins increase. Because if they increase, then there again is a high risk of NSTEMI, and that patient should be ruled in and go directly to the cardiac ward. We also have this condition of unstable angina pectoris, which means that there is ongoing ischemia, but it's not serious enough to cause myocardial necrosis. And these patients, they have stable troponin concentrations, and you need to use clinical assessment or clinical risk scores to identify those patients. There is also a very rare condition of so-called late onset myocardial infarction. And these are patients who present with ischemia. They are typically presumed to have unstable angina pectoris, but then 6, 8, maybe 10 hours after admission, even though they have treatment, they might develop a myocardial infarction. And of course, this cannot be identified on admission. So these patients is a challenge when we use these algorithms. Luckily, though, it's quite rare, and there is large amounts of data, more than 20,000 patients in different studies, around the world who has been evaluated using this kind of algorithm, and it has been shown to be very safe. There is some important things to remember, though. There are assay-specific cutoffs, so you need to know which assay you are using, and you need to know the cutoffs for your assay. These cutoffs are published regularly, and for instance, for the troponin assay for Mindray, which Professor Plebani showed you yesterday, there are work in progress now, and we expect this to be published later this year. So that is, we are looking forward to see these data. So, single sample rule-out is not so difficult by itself. However, if you need to use a 1-hour sample in addition, it starts to get a little bit more complicated. So why should we do this? Well, we know that 70% of patients presenting with acute chest pain, they do not have acute coronary syndrome. And most of these patients, they do not need to be admitted to the hospital. At least 50, maybe 60% of chest pain patients could be discharged if we could, with a high degree of certainty, inform the patient that this is not a myocardial infarction. So, this picture here is, I'm very glad this is not from my hospital, it's from another hospital, but what is shown here is a problem that is seen, I think, globally, all over the world. We have had not as bad as this in my hospital, but we have had some tendency towards this. And this is ambulances which are ramping up outside the ED, the emergency department, and they are not able to deliver the patients because it's so crowded in the emergency department that there is nowhere to put the patient. And this is not due to COVID-19. This is after the COVID-19 pandemic. So what we know is that the pressure on emergency departments is increasing and increasing, and they are not able to get the patient through the system. And one of the reasons why they are not able to do that is because it's so crowded inside the hospital, too many patients in every ward, so they cannot get anyone out of the emergency department. So therefore, we cannot admit the low-risk patients for safety reasons. We have to investigate them in the emergency department and then decide if they should be admitted or not. So this single sample rule-out and 0-1-hour rule-out has been recommended for a long time. However, it's not easy to implement. It's not about, you can, of course, easily change the timing on when you take the samples. That's just a decision, not at 3 hours, but after 1 hour. But to get the effect which this algorithm can give you, you have to change the workflow in the emergency department. And that is not easy, because that involves the cardiologists, the emergency physicians, the laboratories, and often also the radiology department, because some of these patients who are discharged, they need to come back within 1-2 weeks to have a CT coronary angiography. So you have to make a pathway also for this being available in a few days. So at least 4 departments, 3 to 4 departments, and then there is the staff, it's the doctors and the nurses, the technicians, maybe the secretaries, and all these staffs and all these departments need to collaborate to get this thing implemented. So it's not easy. And if we do not implement it the way it's meant to be implemented, we will not have any effect of just moving the timing of the sample. So if you want to do this, you need to have a large process around it, where all stakeholders are engaged and involved, or it will be very difficult to succeed. And many hospitals in Europe, America, are struggling to do this, based on the feedback we get. This is just to sum up of the whole article. So, if we are going to take very serious decisions for patients based on low concentrations of troponins, we need to have a good quality so that we do not make the wrong decision due to low analytical performance. And we have given some recommendations also for these. And what I would like you to know is that these are derived from a theoretical approach. It is not clinical data. Those has been presented in clinical studies. So this is more like a theoretical calculation of the analytical performance needed. What we have done is we have used the standard deviation instead of the percentage CV here, and then we have calculated how large CV you can have without changing the whole numbers, which are, as troponin is reported in whole numbers. And this is the recommendations for the different cutoffs that are used for single sample rule out. And as you can see, if you are around 10-15% CV, most of the time you will be good. For most cutoffs you are good if you are around that CV. And that is doable for most of the assays today. Also, we have done a similar calculations for the delta value, which is used in the 0-1 hour and 0-2 hour algorithms. Then we use biological variation and reference change values for the calculation. And these are the suggestion for the delta value. This is a little bit theoretical, so I recommend that you go and look in the paper if you are interested in this. I have already mentioned this with lot variations, and I think this is very important for troponin assays. But as you can see, if you have an absolute cutoff value, all patients who present with a circulating concentration corresponding to that absolute cutoff, for instance 5, all patients who present with 5, half of them will be measured below the cutoff and half above the cutoff. And this is due to analytical variation. We cannot do anything with this. This is the way it is. However, if you have a cutoff of 5 and then you get a new lot, which is one standard deviation lower compared to the one you had, then these patients who are exactly on the cutoff, it's not half of them that will be measured below the cutoffs, but it's 86%. And again, 84%, sorry, 84%. And again, if it's 2 standard deviations below the cutoff, well, then only 2.5% of the patients who are exactly on cutoff using the old lot, which was maybe applied when this cutoff was decided, will be above. So these lot variations tremendously affect the efficiency of these algorithms. It doesn't affect so much the safety, because most patients with myocardial infarction will have much higher concentrations when they present and not be affected. But the efficiency will be very much affected, because those patients who are ruled out, they are typically around the cutoff. So therefore, this is important to pay attention to, both for laboratories and for manufacturers. We did some years ago, took all the patients who came to the emergency department. We didn't check anything about the diagnosis, but every troponin that came from the ED, we checked percentage of patients eligible for rule out. And as you can see, depending on having a high or low lot, this would very much affect the number of patients who were eligible for rule out, going from 30% to 15%. So it could be doubled based on the lot. So then you understand how this can actually affect the efficiency of your assays, of the algorithms, sorry. Again, to sum up, if you want to do a single sample rule out, 01, 012 algorithms, you need to have a high sensitivity assay. You need to monitor the analytical variation at the concentration corresponding to the cutoff used for single sample rule out. And this is a very good news for the lab managers. If it's not possible, or if you do not want to buy those very expensive EQA materials provided by commercial companies, you can make them your own by pooling plasma or serum. This is very commonly done. Also, you must participate in external quality assessment schemes. I understand you have very good schemes here in China, so this should be used. And you can also monitor the lot variations of the assay. And I have provided some instructions for that in this earlier paper. We have some information on how we do that locally. So, very briefly on interference of troponin assays. There is some recommendations also regarding this. It's for all immunoassays, we have antibody-mediated interference, and so also for troponins. And here you have the normal assay on the top with the capture and detection antibody. Then you have a heterophilic antibodies in the middle, where immunoglobulin will bind unspecifically to, there by that you get a reaction and measured as an increased concentration. And then on the bottom we have the situation with macrotroponins, where immunoglobulin G binds to troponin and they form large complexes. These are circulating, and we think that they are biological, completely have no relevance biologically, but however, they circulate, and when we measure troponin, we will measure higher concentrations due to these complexes. It's similar to macroprolactin, for those of you who are familiar with that. And these patients, they will have a stable concentration of increased troponins. What we recommend is that if the cardiologist asks you about a patient which they have probably investigated many times clinically, a lot of imaging, still there is an elevated troponins which they cannot explain, we recommend to just measure additional troponin assay. So I will send that sample to the neighboring hospital and have it measured with another assay, which is different from the one I use in my hospital. And if then it's normal at the neighboring hospital, I have a very strong suspicion that this is a macrotroponin and interference. Also, it's possible to do a different kind of special investigations to check for this. For instance, you can do spin columns or PEG precipitation to check for this. These methods are described in more detail in this paper. So, to conclude, we need robust and we need accurate determination of the 99th percentile to make an accurate and standardized diagnosis of myocardial infarction. The single sample rule-out algorithm is very useful to efficiently identify people with low and high risk of myocardial infarction, and if implemented correctly in the hospital, it can very much save time and lead to reduction in admission. However, it's important for the laboratories to have very strict analytical performance if this is used and monitor it closely. Also, very few cases, the clinical picture and the troponin concentration will not match, and then you need to check for interference. And finally, I do wish to again welcome you to the webpage of the IFCC in general, and also to the Committee on Clinical Application of Cardiac Biomarkers for more information. So thank you.